Hello, aligner doctors. This is the first video of a series on diagnosis that it's been long overdue, something I've been wanting to do for a very long time. And I'm going to start today with morphogenetic patterns in orthodontics, which is definitely the aspect of treatment, of diagnosis that is most neglected by GPs. And it is the one thing that has the most impact in the outcomes and the predictability of results. And being able to recognize these patterns also helps tremendously doctors stay out of trouble. Let's just go through a quick definition. As morphology, basically it's just the study of form and shape. It includes size, shape, the arrangement between the jaws, and the internal organization. And when I read this definition, I can't help but think of internal organization as the dental aspect. So you have the position and the shape of the jaws and how the teeth relate to each other depending on how the jaws are relating. The genetic component, as obvious as it is, it's not just the genetic information that comes from the family, of course the parents, but also the ethnic group. So we learn to recognize patterns, and we know that certain ethnic groups, regardless of their genetic component from a family standpoint, some ethnic groups tend to behave, their jaws tend to behave a certain way. And while I'm at this topic, let's talk about how do we recognize these patterns. And that's what I think one of the things that separates and makes a big difference between GPs and specialists is that we're exposed to these patterns for so long and so many more times per day that we understand how the way we apply forces to teeth and what we're doing to the teeth interacts with the morphogenetic pattern, and therefore we're more capable of interpreting and seeing these patterns before we get into trouble. So my goal with this short series is introduce the patterns, and maybe and hopefully you all are going to start looking for these patterns in every patient, and it's going to start to become more clear how the patterns interact with treatment. I remember back in dental school that, and this, I don't know if this is still the same, and I guess I'm going to go ahead and get rid of my camera at this point. I remember back in dental school, and I don't know if this is still the same, and this is not really the morphogenetic pattern, but I remember selecting teeth for dentures, and we would look at the shape of the face and try to match. And this, I don't know if this is something that GPs still do or not, but it's sort of similar to what we do with the morphogenetic pattern and the treatments that we're going to do. So let's look again at a little bit at some definitions here. The pattern comes or it drives the growth direction of the patient. So if you're treating an adolescent patient, they have a certain component of how the lower jaw is going to grow. If it's going to grow more horizontally, I guess that would be a good time maybe for me to bring my camera back. So when we're looking at the maxilla and mandible, if they're going to have a more antero-posterior growth, and that will essentially going to determine the skeletal relationships. How, if we're going to end up with a class 1, class 2, or class 3, or a balanced skeletal relationship, or a small mandible on a class 2, or a exaggerated growth of the mandible relative to the maxilla, or even a underdeveloped maxilla, which basically is going to give us that class 3 component. So that is the part that most general dentists see. They associate the growth in a static way, just looking at the occlusion from a one-dimension standpoint. And of course that has some dental influence, and it's going to basically determine the overall facial proportions. What I want to bring in today is to recognize or at least start the conversation to see how exactly these facial patterns interact with moving teeth. So I have a slide here just to kind of make it a little bit more lighthearted. Let's look at this here. And so we have what we would consider our normal divergence. So we talk in terms of divergency of the face, and it relates basically with the middle third and lower third of the face. And here I'm not really using thirds, I'm just using the interpupillary line of the dogs here to exemplify that we have a balanced face, a small lower third, and a very long lower third. And we've all learned how to recognize that in our patients as well, right? But a normal divergent, it's statistically the largest group in the Caucasian population. Okay. Then we have the hypodivergent, which is also known as short face syndrome. And you can start to create associations of what we're going to see in the dental relationship when you're looking at these facial patterns. So we're going to probably see a deep bite, maybe even an underbite. So see, now I'm starting to mix a vertical component with an anteroposterior component, an underbite and a short lower face. Or maybe the hyperdivergent, which is the long face syndrome, and it may be a mouth breather, weak muscles, and a long lower third, maybe a gummy smile. So you start to kind of see these characteristics, and they, again, how we should plan our clean check and what we should expect out of the movements of our clean check is very different within these patterns here. Let's move on to another text slide here. And I've mentioned this before. We do need to have an accurate diagnosis. We need to put the patient in one of those categories and understand and recognize that some normal divergent patients, they may be not clear-cut normal divergent, they may be slightly hyperdivergent. And to keep us out of trouble, we're going to treat that patient more as a hyperdivergent or a long face. And vice versa should be also the case if we're looking at a normal divergent patient and they have some characteristics of skeletal deep bite, not necessarily dental deep bite. We're looking at right now at the facial characteristics, the skeletal underpinnings of the face. If they have a little bit of a hypodivergent characteristic, we need to maybe tailor our treatment, and that's what this comes in. We're going to customize the treatment based on the individual growth pattern. This is going to become clear after this video from today when I start to bring in cases that are clearly fit into the three categories and how we should be looking at these cases. But by going through this exercise and having an accurate diagnosis, and we start to tailor our treatment plans, so being able to build in this pattern into the treatment plan will definitely help us with the outcomes. Not just predictable from a standpoint of achieving the result that we want, but by and large, my goal is to eliminate the patients also that could really land us in a little bit of trouble from undesirable side effects. Okay? And I have a typo on the slide, but let's just move on. So here we have the normal divergent. We have our balanced vertical and horizontal proportions. So if we were to look at a cephalometric x-ray, and again, I totally understand that the GPs are not going to have a cephalometric x-ray, but you really don't need one. All you need to do is to observe the mandibular plane. And let me pause here and get a drawing tool for a minute. All right, so let me get a little color here. So we need to look at the mandibular plane. We need to look at the occlusal plane. We need to look at the maxillary plane. So basically that would constitute from the top of our kind of glenoid fossa to the base of the nose, and see how these planes diverge or converge. And also, so let me erase this, and the facial heights. So we're looking at from the base of the nose to the chin, and then from the base of the nose to the glabella, which is that point between the eyebrows pretty much, and then you have this other top third that goes from basically glabella to to some people the hairline. That doesn't matter very much, but we really want to do look at this proportion here. This is the height that determines the divergency. And what, from a genetic standpoint, the mandible grows in sort of a spiral way. So you have the growth of the back of the mandible, so the ramus, and the more the ramus grows, the more anterior rotation you're going to have on the mandible. So let me delete this and draw this again. The more growth you have of the ramus of the mandible, it thrusts the jaw in this direction. And those are the patients also that you have like a strong chin button. The opposing type facial pattern, the hyperdivergent, you have very little growth of the posterior ramus of the jaw, and you end up with this angle here called the gonio angle. So this angle right here, this is, I would say, a normal divergent, right? If we were looking at a hypodivergent, you're probably going to look at an angle that looks like that. And if you're looking at a hyperdivergent, there is less growth of the condyle process and the ramus, and you end up with a lower jaw that looks more like this. And you can see how that would impact the lower third and all the characteristics that go with that. So the open bite, the deep bite, and the average, let's call it the average bite. So I'm going to repeat this over and over again, just because I want to really sort of impart how important it is to be observing this when you're doing you're taking your records. You're palpating the lower mandible, the lower border of the mandible. You're looking at the patient from a profile view and trying to ascertain, what kind of mandible are we working with here? Okay, so you really don't need a Ceph to do that, but you need to just be observing for it. So I have probably a better diagram now. Now this one here is not looking at dogs anymore. So we have here the normal divergent face, the hypodivergent face, a very strong chin button, very square jaw, lower facial third, relatively reduced compared to the upper, and the classic hyperdivergent or long face syndrome with we would call this as a short upper lip. It's really not that short. The upper lip that short is the maxilla is very long, and you have a gummy smile. And sort of that mouth breather, eye drooping sort of characteristics. Okay, so patients, when we go in to see new patient exams, we immediately start looking at these characteristics because they're extremely important. And here is a better representation of what I was trying to draw a minute ago. So you see how long the ramus is, the posterior aspect of the condyle process there, which ends up with a very square jaw, the average, and a long, skinny jaw. And you can start to appreciate that. And I want you to imagine this. The majority of the hyperdivergent patients, the majority are not going to have a deep bite, right? So they're either going to have a normal overbite or an open bite. But you can have some patients that have a hyperdivergent skeletal profile and still have dental deep bite. Those patients, we can open their bites with treatment very easily. So if you're trying to open the bite on a hyperdivergent, that happens very fast. And with that, what that means is any extrusion of the posterior teeth, any premature contact will prop this bite open in no time. So this is a sort of a danger zone. Orthodontists, we do not like to treat hyperdivergent patients because they can prop open and things can get out of control very easily. Looking at the hypodivergent, most hypodivergents have a deep bite, and it's very difficult to open the bite because we're trying to extrude posterior teeth, and the forces of mastication, the muscle patterns, masseter pull, and they're so strong that it's very difficult to extrude teeth enough to rotate this mandible and open the bite. So here, any extrusion of teeth moves the wedge of occlusion further posterior, and you see this jaw just drop this way very, very easily. On a hypodivergent, we're trying to extrude posterior teeth to try and rotate the mandible and open this bite here, and it's nearly impossible. So that's what you should be basically looking at on these cases. Okay. So let's erase this here. And here, just another table, you know, very straightforward. In normal divergent, we have well-balanced facial proportions, balanced thirds, and we've discussed this. The hypodivergent has a deep bite in general, strong chin, reduced facial height, square jaw, and a hyperdivergent, we have an open bite tendency, a weak chin, so there's very little chin protrusion, and that long face syndrome. Here's what the cephalometric x-ray would look like on a lot of these patients. So let me get my picture out of here. So classic hypodivergent, deep bite, strong chin button. The mandibular plane angle is pretty much parallel to the occlusal plane and parallel to the maxilla. In a normal divergent patient, now we're kind of somewhere in between, and this is classic surgical hyperdivergent. The trouble is, and again, there are patients that sit here, right in the middle here, between the normal divergent and the hyperdivergent, and here in the middle. These are easy to spot and easy to predict or to recognize the pattern. When you start to look at these cases more and more, that's when you start to see the cases that are somewhere, you know, and if we could say that this is a bell shape, which it's really not, right? But if this was a bell shape distribution, the patients that fall in here are the ones that are hard to recognize. These here are easy to recognize, and then you have the normal divergent, but that's the area that we have to focus on in trying to be careful in recognizing these patterns. Now I'm going to finish off with this concept here that so far I've been talking about the vertical aspect, but the reality is that morphogenetic patterns are three-dimensional. So you do have the vertical aspect. You also have the antero-posterior. So this picture here shows a class 1 on a normal divergence. So you have a mandibular plane angle, and the maxilla and mandible align fairly well in the antero-posterior. You can have a normal divergent class 2 that looks a little bit hyperdivergent because it's a small mandible, but the mandibular plane is still within the normal divergent range, but the maxilla and mandible are not imbalanced. And these are okay as far as treatment. They typically behave really well. And then you have the class 3 normal divergent. And you can just kind of look at this, pause the video, and you guess what we're going to look at. The hyperdivergent class 1, the hyperdivergent class 2 is a nightmare. The hyperdivergent class 3 is a nightmare. So as you get to the hyperdivergent, you really want to try and steer away from these cases. And the hypodivergent are very lenient in the sense that you have to really, it's really hard to open the bite. So if you have an issue with overbite, but you're probably not going to see a tremendous issue with trying to open the bite and creating an anterior open bite, because the muscle pull is so strong. So class 1, class 2, class 3, you can do just about anything on these cases. They behave pretty well. So I would try to stay in the normal divergent to hypodivergent cases if at all possible. And then last but not least, that we cannot see here, that's also part of this sort of characteristic, is the transverse, is the width of the maxilla and mandible. And to just die in here, On the hyperdivergent, they tend to be narrower. So you have narrower maxilla, narrow intercanine width. So we're talking about the dimension of expansion. Hypodivergent tend to have very broad mandible and maxilla. So we tie in these 3 dimensions together as the very first step in proper diagnosis. I cannot emphasize enough how important it is to look at these characteristics. So talked already for 20 minutes. I've been trying to cut back on these videos some, but this is a super important concept. I'm going to probably record this again and improve on how I explain these things, but I want to put this out as soon as possible, and I'm going to start following this lecture here, this explanation. I'm going to start posting some cases that are clearly normal divergent, clearly hyperdivergent and hypodivergent, and how my thought process changes between these patients in terms of the moving of the teeth. All right, I hope you guys find this helpful, and it's extremely important. Again, cannot emphasize that enough. Thanks. Bye.